Well, with this week's Cardiology Countdown, we'll start up in Canada with a very interesting look at hospital spending versus mortality and readmissions. This was a look across several different diagnoses, including acute MI, heart failure, and hip fracture, and looked within the Canadian system at hospitals that spend more versus less for a given diagnosis and relating that to outcomes. And they found that the hospitals that spend more per patient had longer length of stay, not surprisingly, but lower mortality, suggesting that all of that extra work and spending may be beneficial to patients. And so an intriguing look from an unusual source where cost containment is thought of, that in fact more aggressive treatment in some cases may be better. At the number 2 spot is a biomarker sub-study, a collaborative meta-analysis looking at interleukin-2. There's actually a pair of papers on interleukin-6, and one of them looks at functional alleles as to whether there may be a causal pathway from the interleukin-6 receptor. They found that with functional variants in the allele, there was a dose response as to how many alleles versus a lower risk of cardiovascular death or MI, suggesting that the interleukin-6 receptor and pathway in general, which relates to inflammation, may be causal in developing cardiovascular events. So intriguing genetic and biomarker data suggesting inflammation may in fact be a causal part of cardiovascular events. And at this week's number 1 spot is a study looking at calcium scoring and family history as means of increasing the risk assessment of patients to help identify those who may benefit from primary prevention. With statins, there's great debate as to whether we should be using them in primary prevention or simply emphasizing lifestyle changes. And the rub really comes to identifying those with enough cardiovascular risk where there would be significant benefit of the statins. And so this group looked within the St. Francis randomized trial, used standard dose atorvastatin versus placebo, overall had a trend toward benefit, but they found those who had a calcium score of about 400 or higher and a family history as a risk factor had a significant reduction in events over a 5-year follow-up period. And so this reaffirms the concept that we do need to have risk stratification built into assessing patients for primary prevention, and that calcium scoring and a good family history can be useful adjuncts to picking out who will benefit. So with this week's Cardiology Countdown, I'm Chris Cannon.